Oscar. It's a big pleasure to stay with Oscar, with Mehmet, with Honor, with Visotti, and all our colleagues, Dr. Thomas, and thanks for having inviting me. The topic is the role of posterior fossa decompression in different types of basilar invagination. This is my city. As long as you know, the South Hemisphere has only a third of all lands in the world. We live in a big city, as the cities in Turkey. You are all invited to come to see our country. Basilar invagination, there is a lot of confusion in the diagnosis and treatment. And even now, recently, many informations appeared in the scene, and we must choose which kind of operations we should do. It's a big problem now. New forms of treatment have been advocated. A summary evaluation suggests that the sample of pathologies treated are different in several parts of the world. Now we are working with Oscar and with Dr. Jörg Klickamp from Germany. We are studying the difference in the samples throughout the world. That seems to be very different. We are trying to understand the classification of all craniovertebral malformations. We did a research to understand the distribution of pathologies based on the literature. We did a systematic review using the terms Arnold-Chiari malformations or Chiari, basilar invagination, and atlantoaxial dislocation. Several parts of the world prefer to term the term atlantoaxial dislocation. And we selected only papers describing samples of patients with pathology to understand the difference of the disease throughout the world. And we selected 4,708 described cases from every part of the world. And we were able to find and to put the groups under unstable and stable cases. The unstable case came mainly from China and India, and some centers studying children in the US. And the stable case came from the other parts of the world. When we look at the unstable cases, the unstable are composed mainly by children and male patients, predominantly. Then we can put all malformations under unstable and stable umbrella. And in unstable, it's possible to separate basilar invagination type 1 or A, according to Goel, atlantoaxial dislocation with absence of detached odontoid process, and atlantoaxial dislocation with normal bones. Probably is a ligament problem. This disease is more rare and has been discussed. And in stable branch, we can divide into all forms of Chiari, all types of Chiari malformation, and type 2 basilar invagination or type B, as you preferred. Here are examples of type 1 basilar invagination, in which the assimilation of the anterior arc of atlas is the predominant problem, and odontoid goes through Mac-Ray's line. And instability that we can code by atlantoaxial dislocations are really dislocations with odontoid malformed or only dislocated. And here, type 2 basilar invagination as we know that everyone knows. The topic that we will talk today is type 1 or unstable and type 2 stable basilar invagination. It's very important to remember, and I will show three slides. Remember the normal anatomy. In normal anatomy, the arc of C1 is in front, anterior to the basal, and the odontoid process is in line to the basal. And there is a distance from the basal to odontoid in every normal citizen. Anterior arc, anterior to basal, odontoid in line to basal. This is a magnification and other example. Only to remember, odontoid in line with basal, anterior arc of C1 ahead or in front of the basal. And there is always a distance between atlas and the skull. Always will have a distance, a normal space. A magnification only showing the distance between C1 and C2. In normal, basal is, sorry. In normal, basal is in line with odontoid. In the left, we have a Chiari malformation with tonsil herniations. The anatomy, the angular anatomy, are very similar to normal subjects. C1 atlas is far from the skull. Odontoid is in line with the basal, similar to the normal ones. Okay. At the left, we are another case with tonsil herniation, and the anatomy is very close to normal. At right, we have a typical case of type 2 basilar invagination. We cannot see the posterior arc of the C1 that is assimilated to the skull. This brings atlas very close to the skull in an upper part, and this helps to create a craniocervical kyphosis. Then atlas is in the upper part, different from Chiari and from normal citizens. When we have an anterior arc assimilation that is very common in type 1 invagination, here is the posterior arc assimilation. Then the atlas is closed, is joined to the skull. This brings the odontoid to an upper part. But if you remember, atlas and odontoid process in normal citizens are closed one to the other. The problem is not the height of the odontoid, but atlas is the problem in these diseases. When we look at type 2 basilar invagination, here is the simulation of the posterior arc of atlas that brings the atlas to an upper position. Then again, atlas is the problem. We did a systematic review from several control studies showing where is the atlas in normal population. Atlas related to violation of Chamberlain's line. Atlas normally is not above the Chamberlain line. At the maximum, it may be at the Chamberlain line. Then the atlas above the Chamberlain line is an abnormal pathology. When we study all our samples of types 1 and 2 basilar invagination, 52% of those are composed by type 1, almost 30% by type 2, and almost 20% by type 2, but with normal atlas and axis, not assimilated. Then the assimilation of atlas, in our understanding, is responsible for the greatest majority of this disease. Is a big problem in basilar invagination. When we look at our samples with type 1 basilar invagination, we can see several forms or types of assimilation. There is assimilation with almost horizontal clivus, and the skull is bending to the front. There is assimilation with a distance between C1 and C2. There is assimilation in which the odontoid is stopped by the skull, by basium, and several other types of dislocations in type 1 basilar invagination. When we look at type 2 basilar invagination, the anterior arc is not assimilated, but the problem is the assimilation of posterior arc that also brings the atlas to another upper part. Then it's very frequently the assimilation of the posterior arc of C2 in 60% of type 2 basilar invagination. But there are some cases that if we don't look closely to the bone deformity, we would consider this as a type 2 basilar invagination. But when we look at the bone anatomy, there is an atlas assimilation and an upper migration to odontoid. This that we would consider at first a type 2 basilar invagination is really a type 1. Then the bone anatomy must be studied specifically in all types of basilar invagination. Other basilar invagination type 2, and when we look at the bone anatomy, is really a type 1 basilar invagination. We study specifically the relation of atlas patterns in this malformation. The constant problem in type 1 is anterior arc assimilation, and in type 2, a posterior arc assimilation. In normal development, when the C1 is closed, joined to the basium and to the skull, the odontoid becomes posterior, and atlas are not migrated to the anterior part. After the severance line, the separation between the cervical spine and cranium, the skull bends to the posterior part, and C1 goes to the front. Then atlas became anterior to basium, and odontoid in line to the basium. This is important for the diagnosis. The assimilation of the anterior arc of atlas prevents the heteropositioning of the skull in relation to the atlas, keeping the C1 in line with basium and odontoid projected to the foramen magnum. I insisted abroad in this concept because this is important to the diagnosis. But as you can see here, C1 and C2 are in a normal relationship. C1 is not in the upper part. What is migrated to the upper part is C1. In embryology, there is a suggestion that Hox genes are responsible when the occipital Hox genes are not well formed. The Hox genes from cervical spine make the work by the cranial Hox genes. And when the cervical spine does not work well, the skull try to make the work by cervical spine Hox genes. Then this explanation can explain basilar invagination and all forms of malformations that occur in cranial cervical junction. These two diseases may be separated by another classification and not put all the forms in the umbrella of atlantoaxial dislocation. But there are other important phenomena that occur. These cases are frequently accompanied by platybasia. The base of the skull does not bend adequately and frequently dumps the head to the front with a flexion of skull cervical spine limits. Here is the kind of platybasia that can occur in this disease. When we look at in basilar invagination, at the relationship, the angular relationship between the skull and cervical spine, patients with basilar invagination have a craniocervical kyphosis. Perhaps this must be put into consideration in the treatment. This is a flexion of the skull and cervical spine and can be translated into results. There is a suggestion that not only the occipital make part of this problem, but the sphenoid bone is important in basilar invagination. It's something that we are looking at just now. And also, brachycephaly. When we study type 2 basilar invagination, there is a straight relation to the shape of the skull, and very more frequently in patients with a brachycephaly. We study these relations also, and what we could understand, type 2 basilar invagination are frequently brachycephalic persons. The skull is rounded very frequently, suggesting brachycephaly. And the topic, how do I treat these patients? First, unstable cases. We published this paper almost 20 years ago, and our intention was to demonstrate that several situations that were considered previously as part of the basilar invagination could be normalized with traction and realignment of the skull. The basium may become not horizontal, but vertically, and the cervical spine could lose the hyperlordosis and become more straight when the head becomes more normalized by traction or by surgery. And we propose that craniocervical fixation could treat not only the cervical spine, but the head in relation to the cervical spine. This is a pre-op atlas assimilation, that is the rule. Posterior fossa decompression, treating syringomyelia, and normalization. Even the tentorium became normalized when we realign the head, suggesting in that time that the skull bending could make part of the pathophysiology of this disease. It is a schematic, a diagram showing retro position of the skull and verticalization of the clivus, making part of the treatment of this disease. And here is another publication showing that only with head extension, the atlas and axis can be put in the normal situation. And probably here, we don't need to distract C1 and C2, only to fixate it in the normal, and a now normalized position. This is a craniocervical fixation. And more recently, we have stopped the cervical fixation in C2 to permit the cervical spine to get a normalized position and to control the basal. This is a type 1 basilar invagination, assimilation of the posterior arc of atlas, it makes part of the skull. Then if you fixate the skull or CU or C1, there is no matter because the mechanical effect will be the same. And the fixation stopping at the upper cervical spine, if possible. And associated to decompression of the posterior arc assimilation. We don't realize in smaller decompression. We think that the posterior fossa must be decompressed in the normal position of the patient. Type 2 basilar invagination and Chiari malformation, even Chiari 1, or small tonsillar herniation, because the occipitalization of the atlas frequently stops the tonsil herniation and compresses more the posterior fossa. This case has been, in our experience, been successfully treated by posterior fossa decompression. Even with ventral compression, we get size for the posterior fossa. Even the bending of the spinal cord can be normalized when you get space to the posterior fossa. One case, ventral compression, posterior compression, tonsil herniation, and becomes more normalized with CSF flux in front and behind and cisterna magna recreation only after posterior fossa decompression. There is now a try to increase the clivus canal angle in type 2 basilar invagination. There are only 2 papers that I know trying to make a fixation in type 2 basilar invagination. They got a small increase in ventral angles, in ventral compression. But nowadays, the amount of information is very small. And if associated with brachycephaly and platybasia, we don't have this information until now. C1, C2 distraction and fixation. We have some concerns when associated to clivus horizontalization and craniocervical flexion. What is the effect of C1 and C2 distraction in case like that? Or in case with an horizontal clivus? Well, we probably could not bring the skull to a more normalized position. But in this case that we have the C1 and C2 normalized, but only C1 in the upper portion, if we make a distraction, we will do this, put the odontoid to then a more down situation than is normal. Then our suggestion is to realign, to decompress the posterior fossa and fixate with a decompression of the posterior arc of C1 assimilated. The majority of these patients have a narrow posterior cranial fossa, and we decompress all of them. When to use C1, C2 distraction and fixation only without decompress? In these situations, we have some concern to do that. There is one specific situation that we consider that this will be effortful, is the atlas shrugged. I think that you know this kind of disease is a bending to the side of the skull in relation to the cervical spine. When you look in the sagittal image, the migration of the odontoid is very high, probably because you have a sagittal image in the skull, in the down part of the sagittal reconstruction. in this case, probably the distraction, in some case like that, that you really need to bring the odontoid to a lower part. In this case, the distraction will be very suggested. Then, in basilar invagination, we consider the patterns of atlas assimilation, cranial cervical flexion, horizontalization of clivus, platybasia, brachycephaly, the tightness of posterior fossa and cervical spinal canal, and posterior fossa decompression has been the rule for us until now. We can remember that there's no randomized trials comparing several techniques. The amount of craniocervical realigned techniques published is much greater than C1, C2 distraction techniques. There's more literature with occipitocervical fusions than C1, C2. Even the published results are not clear. Frequently, you cannot see the results in the papers. There's no data over the superiority of C1 techniques over the compressive or craniocervical alignment techniques. The effect of skull and head immobilization should not be neglected. Neither of the C2 nerve resection. We don't know the results, neither the long-term results of any of these techniques. Until more results appear, superiority of any technique should be considered elusive. Well, I finished my data and I'm happy to discuss with you. Thank you for your attention.
Thank you, Ricardo. It was really an amazing lecture, amazing experience you have from substantial number of patients you have in Brazil, and also from your literature review. You are really a great expert on this. So, I mean, this was really interesting what you told us, because you told us that atlas can be the problem, or one of the problems, platybasia, brachycephalia, whereas Professor Gould from India, he focused a lot on the joint, on C1, C2 joint. And my impression is that you were talking somehow on different diseases, and that's why it doesn't show any superiority of any technique in different trials, because we are talking about different, thoroughly different patients. So there are some questions here I would like to open from the audience, if there are any questions. You know, I noticed that you always, when you do some fixation, you always go for a C0. Is this for any technical reason? You know, you avoid C1 because of any danger of the vertebral artery anomaly, or you want to play safe? Is it related to the physiopathology that you can correct by some of the retropulsated head? You know, just explain a little bit more why you're not intervening more on C1 than.
That's a fantastic question. I think that you only know what you see or what you have in your hands. I began studying the alignment between the skull and cervical spine. And I showed, at least for myself, that the skull is bent to the anterior part, to the back. And we can realign the skull and cervical spine, fixating the skull. I don't know until now if we can do that distraction C1 and C2. Then, which is the case for only distract or fixate C1 and C2, and which is the case for stopping in C0? In my patients, the majority of them have craniocervical kyphosis, have a clivus horizontalization. Our patients suggest that we need to realign the skull, but only the results we show the truth for us, Oscar.
Right. No, it's. I mean, it's definitely true. My only concern when you do a C0, C2 fixation without going further down, your leverage arm is too big. So you have run into problems in revision problems, in pull-out screws, I think it's a very short construction with a long lever for the rod. You see my point?
Again, I think that you are right, but C2 is the screw in C2 is a very strong fixation. But I agree, there is a big arm. But if you fixate to the lower part, you will lose the ability of the cervical spine to compensate your balance, the balance that you have created. That's the reason that we bet on stopping in situ and letting the patient to normalize their sagittal balance.
Yeah, I fully agree with you. Whenever you have lordosis in lower cervical spine, you have kyphosis, C0, C2. So this kind of compensatory mechanism needs to exist. I agree with you. So is there any other questions from the panel or from the audience?